Good afternoon, colleagues. Sedation and analgesia in the ICU is one of the important aspects of ICU care and are primarily indicated to prevent self-harm and ensure patient comfort. This afternoon, I hope to discuss the goals in ICU sedation and analgesia, whether it's patient comfort or a deep level of sedation. I will talk about the principle of analgosedation and clarify some misconceptions about it. Next will be about sedation assessment tools and the targets which we want to achieve. I will also talk about the drug choices in ICU sedation and analgesia and some important non-pharmacologic techniques to help alleviate discomfort. And lastly, I will talk about some COVID-19 considerations regarding sedation and analgesia in the ICU. The first thing you have to ask yourself is whether your patient needs to be sedated. And there are only two general goals for ICU sedation: to provide pain relief and patient comfort, and the second is to prevent self-harm, needing a deep level of sedation, which may even need paralysis. If your goal is patient comfort, this means someone who is calm and communicating. They may be asleep, but they can easily be awakened. For the majority of post-operative patients, patient comfort will be your goal, and your options include non-pharmacologic techniques, and I will discuss that later. You can use non-opioids, maybe some opioids, dexmedetomidine, or propofol. If your goal is to have a deeply sedated patient, to facilitate ventilator synchrony, or to prevent increases in ICP, like in cases of traumatic brain injury, or as part of targeted temperature management in post-arrest patients, you have the same drug choices, of course at a higher dose, and the only difference is that with a deep level of sedation, you have an option of giving neuromuscular blocking agents. The first step is to assess for the presence of pain and control it if there is, and if there's none, please don't sedate with opioids. Analgosedation is based on the principle that it is better to treat disease, which is pain, than to mask it with sedatives. It is the practice of treating the pain with analgesics like opioids before actively sedating the patient, because in this way, once pain is controlled, the patient can then be put on minimal or even no sedation, avoiding oversedation. Analgosedation can be defined as analgesia-first sedation. Analgesia-based sedation, on the other hand, is where an analgesic, usually an opioid, is used instead of a sedative to reach the sedative goal. Imagine a patient who is agitated but without any pain. If such a patient were treated with opioids, they would require higher doses of opioids to take advantage of the sedative effect. This is because either morphine or fentanyl is a potent analgesic but a weak sedative. In analgesia-based sedation, you're essentially using high-dose opioids as a broad-spectrum quiet-down drug to treat anxiety or agitation. Bear in mind that the side effects of opioids are dose-dependent. The more opioids you give, the more side effects you get. So I don't recommend this practice, particularly as a primary technique to sedate. Provision of analgesia is very important because ICU patients experience pain at greater rates than other hospitalized patients. Here you will see that up to 80% of ICU patients experience pain, and that the most painful procedures are actually the common ones like tracheal suctioning, drain removal, and patient turning. This paper shows the effects of traumatic experiences in the ICU like pain, fear, anxiety, inability to sleep, and nightmares. You will see here that up to 75% of ICU patients and family members develop anxiety, depression, and PTSD from these traumatic experiences even after 4 years. Of interest is this cohort of 230 patients, which concluded that the incidence and intensity of pain is the same in surgical and trauma ICUs and medical ICUs. This was a survey on the pharmacologic knowledge of the physician house staff and intensive care nurses regarding the analgesic and anxiolytic effects of narcotics, benzodiazepines, and neuromuscular blockers. The results showed a commonly held misconception that muscular paralysis is a calm and painless state, as well as diazepam's pain relief. Opioids are the most frequently used drugs for pain in the ICU. In fact, up to 90% of ICU patients receive opioids. Remember that they don't have amnestic effects, and so be careful about awareness and recall. They also have several adverse effects like respiratory depression, nausea and vomiting, ill use, tolerance, withdrawal, and hyperalgesia. Also, opioids in itself can cause delirium, so bear in mind this side effect as well. I would like to emphasize that because of the wide variation in opioid requirements between patients, the effective dose of an opioid is determined by each patient's response, not by the dose range. A popular opioid in the ICU is morphine. It has active metabolites that can accumulate, particularly in those with renal dysfunction as well as in liver disease. Another opioid is meperidine. Although some would use it for renal or biliary colic, it actually has no role in pain management in the ICU and is not recommended because of its metabolites that can cause CNS excitation, seizures, and even more agitation. Remifentanil is a potent, ultra-short duration opioid that does not accumulate even in hepatic and renal failure. It has the same side effects like the other opioids like hypotension, bradycardia, and chest wall rigidity. You can also develop tolerance from it after some time. Another important concern as well would be the development of hyperalgesia, which might require more rescue doses of opioids after you stop it. The most popular in the ICU is fentanyl because of its rapid onset. Nice thing about it is that it is essentially a clean drug. If your patient is awake, the best way to administer your opioids in the ICU is by a PCA. With a PCA, the patient gets a psychological benefit of having autonomy and control over his or her pain. It is practically safe because of the inherent safety principle. You only get what you need. This slide shows the standard prescription of the PCA. Note here that the patient should be comfortable before starting the PCA, which means you may need to give titrated boluses to control the pain before starting the PCA. Also note that we don't give a continuous rate unless you have a chronic pain patient and you already know his or her opioid requirement. This is the WHO pain ladder showing how to start your analgesics. And as you can see, we should start with non-opioids like paracetamol and adjuvants, then progress to strong opioids and interventional techniques. These are some adjunct non-opioids which will help in reducing opioid and sedative use. Following the WHO pain ladder, start with these non-opioids first before giving opioids so that if we are able to control pain with these non-opioids, then we are able to avoid opioids and its side effects. Regional anesthesia can also be used in ICU patients. They provide significant pain relief and will reduce or even avoid opioid and sedative use. Ketamine is an NMDA antagonist which provides intense analgesia even at subanesthetic doses, which may prove to decrease opioid use. It may, however, precipitate hallucinations that can be attenuated by simultaneous benzodiazepines, but usually these hallucinations are mild and easily controlled by decreasing the infusion rate. At low infusion rates, psychomimetic side effects are not really a major problem. Top tip number 2 is target an awake, communicating patient shortly after intubation. Deep sedation is understandably used following intubation in the ER or operating room in order to facilitate safe transfer to the ICU, but more often than not, deep sedation is continued on admission to ICU. This multi-center prospective longitudinal cohort study from 25 Australian and New Zealand ICUs involving 255 patients identified that deeply sedated patients within 4 hours of commencing ventilation and after 48 hours had longer time to extubation and higher hospital death and 180-day mortality. This confirms that more sedation is not necessarily better. This RCT of 137 ICU patients requiring mechanical ventilation, which looked at the subsequent patient mental health of lightly sedated versus deeply sedated patients, suggests that light sedation reduces ICU stay and duration of ventilation. Top tip number 3 is to use appropriate non-pharmacologic and pharmacologic interventions for different symptoms, ideally with patient input. The ideal situation is an awake patient who can communicate his or her symptoms so that the caring team can provide the appropriate medication to treat the specific symptom. While pharmacologic agents are often necessary to manage pain and anxiety, their use may be reduced and effectiveness enhanced by multifaceted non-pharmacologic interventions. When we've decided that our patient needs sedation, the next question is, what is the ideal sedative drug? The answer is none. No single medication can address pain, anxiety, agitation, and sleeplessness all at the same time. Therefore, several medications at low doses in combination may be required to obtain different benefits and to minimize its side effects. For others, the ideal sedative is only what the patient needs, and for some, it may be nothing at all. Again, if a patient is in pain, give a pain reliever and not a sedative. If the patient is agitated but not in pain, give a sedative and avoid opioids. Although lacking a strong evidence base, antipsychotics like your haloperidol or your atypical antipsychotics may be used for patients who experience significant distress secondary to delirium, such as hallucination and/or delusion-associated fearfulness, or who are delirious and have agitation that may be harmful to others or themselves. Antipsychotics, however, should be stopped immediately following the resolution of the patient's distressful symptoms. Known adverse effects are QT prolongation, hypotension, and neuroleptic malignant syndrome. In this randomized double-blind placebo-controlled trial by the Mind USA investigators involving 566 ICU patients with delirium, haloperidol or ziprasidone as compared with placebo, did not significantly alter the duration of hypoactive or hyperactive delirium. It should be noted, however, that 89% of those with delirium had the hypoactive type, which could be interpreted as a non-improvement. Melatonin is a hormone that plays a central role in sleep-wake regulation and decreases the breakdown of tryptophan and serotonin through negative feedback. Due to the lack of high-quality evidence, the PADIS guidelines made no recommendation regarding the use of melatonin to improve sleep in ICU patients. It may, however, be a treatment option on the basis of its physiologic mechanism and also because it has an impressive track record of safety, being available over the counter. Having in mind the cost of ICU delirium versus the cost of melatonin, even if it's marginally effective, it becomes a cost-effective option to improve sleep and reduce delirium. This double-blind RCT in 2015, comparing melatonin 6 milligrams versus placebo, showed that melatonin decreased the need for sedation and also improved neurologic indicators with reduced costs for neuroactive drugs. It also hastened weaning from mechanical ventilation. This double-blind randomized placebo-controlled study, published 4 months ago, involving 203 adult ICU patients given analgesics and/or sedatives, showed that melatonin was associated with better sleep quality. Dexmedetomidine, a selective alpha-2 receptor agonist with anxiolytic, sedative, and analgesic properties, is a popular choice for sedation because it has minimal respiratory depression. With dexmedetomidine, patients can be aroused without discontinuing the drug infusion, and when awake, patients are able to communicate and follow commands. This has been called cooperative sedation and is similar to temporary awakening from sleep. In fact, the EEG changes in this type of sedation are similar to the EEG changes in natural sleep. It can be used as a sole sedative drug for light sedation, but is not suitable when deep sedation is required. It is associated with less delirium than other sedatives and may be the drug of choice for the treatment of delirium. In addition, it has no active metabolites, making it a popular choice for patients with hepatorenal dysfunction. Common side effects include hypotension and bradycardia, often with a loading dose. It has a role in weaning sedation, as well as during the transition period from mechanical ventilation to spontaneous breathing. In this open-label randomized trial comparing dexmedetomidine as the sole or primary sedative versus the usual sedatives like propofol, midazolam, or other sedatives, subgroup analysis showed lower mortality with dexmedetomidine in older patients. Propofol, as you know it, is a hypnotic with anticonvulsant and antiemetic properties, but no analgesic properties. It has no active metabolites. It is delivered in a fat emulsion that provides 1.1 kcal per mil, so consider this when adjusting nutritional requirements. Common side effects include hypotension, myocardial depression, and respiratory depression. It can also cause pancreatitis and the rare propofol infusion syndrome. It is recommended to avoid giving more than 4 milligrams per kilo per hour and to monitor your CK and triglycerides daily when given longer than 2 days. The latest 2018 PADIS guidelines suggest using either propofol or dexmedetomidine for sedation in critically ill, mechanically ventilated patients. This multi-center double-blind trial 2 months ago, involving 422 patients given light sedations, looking at the days alive without delirium or coma, ventilator-free days, and 90-day mortality, concluded that there's no difference in outcomes between those given dexmedetomidine and those given propofol. We've discussed about several drug therapies to provide patient comfort, but also important are the use of non-pharmacologic interventions for patient comfort, and this is top tip number 4. This quality improvement study on 116 ICU patients who were asked about the quality and quantity of sleep and the factors contributing to poor sleep reported that the quality of sleep of 59% of patients were poor or very poor compared to 24% at home. In addition, 76% of patients responded that they did not have a normal sleep-wake cycle, and the 5 most frequently cited reasons for this were noise, pain, light, loud talking, and intravenous catheters. These stressors generate discomfort, anxiety, and may promote delirium. These are some non-pharmacologic measures that are relatively low cost and safe and may reduce patient and family anxiety or stress. Minimize noise, ensure communication by using visual aids, word charts, and writing tools, orient the patient to place, day, and time frequently, reduce ambient lighting during nighttime, music therapy, comfortable positioning, and ensuring ventilator synchrony. Top tip number 5 is when deep sedation is needed, de-escalate ASAP. Some ICU patients require deep sedation to facilitate specific interventions such as management of ICP, prone positioning, and neuromuscular blockade. The need for deep sedation should be assessed frequently, at least 4 times daily, and once the indication for deep sedation has resolved, medications should immediately be reduced and stopped. This RCT of 137 ICU patients requiring mechanical ventilation, which looked at the subsequent patient mental health of lightly sedated versus deeply sedated patients, suggests that light sedation reduces ICU stay and duration of ventilation. This multi-center RCT, the ABC trial, involving 336 patients who underwent either daily sedation interruption plus a daily spontaneous breathing trial or a daily SBT alone, showed that patients in the daily sedation interruption plus SBT group had more ventilator-free days and were discharged earlier from ICU and hospital. It's interesting to note here that there was an increase in self-extubation rates in the daily sedation interruption plus SBT group, but no increase in the rates of reintubation. The graph on the right is a comparison of 1-year survival, showing that patients managed with the spontaneous awakening trial plus SBT strategy were 32% less likely to die than patients in the control group. This multi-center North American RCT sleep trial, involving 430 patients who underwent daily sedation interruption plus protocolized sedation or protocolized sedation alone, showed no difference in the duration of mechanical ventilation, ICU, and hospital stay. There was, however, higher mean doses of sedatives and higher self-assessed nursing workload with the daily sedation interruption group. The message here is that daily sedation interruption offers no additional benefits when you have a sedation protocol targeting light sedation. You're called by the nurse for an agitated patient. What will you do? Will you give an antipsychotic to the nurse? Will you give diazepam to the patient? Or take morphine for yourself? or look at the patient. You're a good doctor and so you will assess the patient. Despite a systematic process, pain remains to be a major stressor in the ICU. In fact, chronic pain is increasingly being recognized as a sequel in survivors of critical illness that negatively affects quality of life. A possible cause explaining this problem is because pain is either inadequately treated or not properly detected. It is common to use hypertension and tachycardia as indicators for the presence of pain, but these papers show that hemodynamic measures like your blood pressure and heart rate are not suitable indicators as they can remain unchanged in the presence of pain. Clinical practice guidelines tell us that vital signs used alone are not suggested for pain assessment in adult ICU patients. This leads me to top tip number 6, which is to use assessment tools and set a sedation level target. This is the Richmond Agitation Sedation Scale. A target sedation score is set regularly, like twice daily, and the default is set to target a comfortable, oriented, alert, or easily rousable, cooperative patient, and this is a score of -2 to 0. If you're managing ICPs, seizures, severe ARDS requiring muscle paralysis and prone positioning, then you need a deeper level of -3 to -5. Patient self-report is best for pain assessment using the numerical rating scale on the left, and if unable to communicate, use the critical care pain observation tool on the right. Another is the behavioral pain scale, and both are valid and reliable. This should be done every 4 hours, and a rating scale of 4 or more and a CPAT of 3 or more predicts the presence of pain requiring intervention. This is the confusion assessment method for the ICU tool. It is recommended that you do the assessment once daily or more frequently if the patient's behavior changes. If 1 plus 2 and 3 or 4 present, then you have delirium. This cohort study testing the CAM-ICU tool involving 96 patients showed that delirium is extremely common in mechanically ventilated patients. 8 of 10 patients have delirium. Of interest is that delirium is present in 4 of 10 alert or easily aroused patients who are usually assumed to be cognitively intact by ICU staff, and delirium persisted in 10.4% of patients at hospital discharge. The most common type of delirium, hypoactive or quiet delirium, is often not recognized because it is not overtly problematic compared to the hyperactive or agitated type, but may portend a worse prognosis than hyperactive delirium. This cohort of 275 mechanically ventilated patients showed that delirium was an independent predictor of higher 6-month mortality and longer hospital stay. Top tip number 7 is to use an intermittent or a PRN bolus of benzodiazepines for palliation, seizures, procedural amnesia, and alcohol withdrawal. Top tip number 8 is to identify opioid and benzodiazepine withdrawal because prolonged treatment with these drugs results in physiologic dependence, and rapid tapering or abrupt discontinuation can precipitate iatrogenic withdrawal syndrome, which may be associated with adverse outcomes including agitation, delirium, and prolonged mechanical ventilation. This study involving more than 1,100 pediatric ICU patients showed that iatrogenic withdrawal syndrome is common in those who receive greater than or equal to 5 days of opioids and sedatives. Top tip number 9 is to remove unnecessary catheters and drains to improve patient comfort, reduce agitation, and facilitate mobilization. Physical restraint use should be avoided or minimized as it causes patient injury, increased agitation, and psychological distress for patients and family members. This paper on 31 surgical ICU patients who had unplanned extubations noted that the use of restraints does not tend to prevent unplanned extubation. In fact, 87% of patients who self-extubated were restrained, and half of these patients were reintubated. They also estimated a $1,000 additional cost for every reintubation event. This study on more than 1,700 subjects intubated for mechanical ventilation reported that physically restrained patients were 5 times more likely to experience unplanned extubation. Top tip number 10 is do not increase sedation at night for the purpose of promoting sleep. The secondary analysis of the sleep trial, involving 423 mechanically ventilated patients, found that patients receive higher doses of opioids and benzodiazepines at night, and higher nighttime doses were associated with SVT failure and delayed extubation. This highlights the importance of minimizing sedation at night as well as during the day, and sedation should not be increased at night for the purpose of promoting sleep. Melatonin or non-benzodiazepines can be considered for sleep promotion in addition to non-pharmacologic measures. The ECASH concept, which means early comfort using analgesia, minimal sedatives, and maximal humane care, aims to establish optimal patient comfort with minimal sedation as the default presumption for ICU patients. Pain relief and light sedation will promote sleep, early mobilization, and improve communication of patients with staff and relatives, all of which may be expected to assist rehabilitation and avoid isolation, confusion, and possible long-term psychological complications of an ICU stay. The ECASH concept basically summarizes the integrated approach to ICU sedation. Analgesia alternatives in COVID-19 include maximizing your non-opioids, PRN boluses first before deciding on an infusion, enteral opioids using continuous release preparations, the use of fentanyl patch, and COX-2 inhibitors when the risk is low. Light sedation alternatives include the use of clonidine, sub-anesthetic doses of ketamine, intermittent benzodiazepines, enteral diazepam, or the use of antipsychotics. Deep sedation alternatives include using ketamine at more than 0.4 to 1 mg per kilo per hour, or the use of volatile gases either using anesthesia machines or anesthetic reflector devices. Guidelines and recent reviews based on the RCTs suggest that NMBAs should be avoided in ARDS unless there is moderate to severe ARDS, ventilator desynchrony despite deep sedation, prone ventilation, and high level of inspiratory efforts. As needed or intermittent boluses are preferred over continuous infusion for up to 48 hours. When you have a limited supply of atracurium or cis-atracurium, you can use vecuronium or rocuronium in patients without organ dysfunction given as intermittent or PRN boluses. In summary, pain assessment is very important before starting any sedative or opioid, and this is the practice of analgesia first sedation. Remember to follow the WHO pain ladder and consider non-opioids first before the opioids. Target an awake, comfortable, and communicating patient, and so less sedation is better. Multimodality and multifaceted non-pharmacologic interventions reduce sedative use. And lastly, use assessment tools with appropriate sedation targets to improve outcomes. We have to individualize our approach in sedation because ICU patients have different requirements, comorbidities, organ dysfunctions, risk, severities, and at different stages of their disease.